Give the invocation.
Dear Heavenly Father, thank you, Lord, for this beautiful day. Lord, be with us as we go through the council meetings today. Just bless everyone's here, Lord. Bless council and the audience, and just be with us, Lord, and give us wisdom, understanding as we do our work today. And we ask this and blessings in your precious name, Lord. Amen.
Thank you. Miss Shelley, will you call the roll, please?
Noel Fulbright,
Present.
Dick Legg,
Here.
Jack Baker,
Here.
Harley Bezzard, Joe Bird,
Audie.
Julia Kentz, Jody Fishinghop, John Garvin, Hannah Glory Jordan,
Present.
Frankie Hargis,
Present.
Lee Keener, Curtis Snell,
Here.
Miss Taylor, here, David Thornton, Victoria Vesquez,
Honey.
Miss Dick, Karen Callan Watts.
Honey.
We do have a quorum.
Thank you. The chair will entertain a motion for approval of the minutes.
So moved. Second.
We've had a motion and a second. All in favor of approving the minutes, let it be known by saying aye. Aye. Any opposed? Okay, the minutes are approved. We'll go right into reports, and we're going to hear from Claremore first. Is there anybody here from Claremore? Don't see anybody today. Maybe they'll come a little bit later. We'll go right in for Cherokee Nathan Health Services, and Dr. Grimm is going to be reporting to us today, and we always enjoy hearing from him. Give us a big update on everything going on.
Thank you, Counselor. We have a lot going on, as always. All right, I'm going to try to present on some does and a few different that at all of our clinics. We are up in our visits, and I wanted to give you a different way of looking at things than we sometimes do. I don't know about you all, but sometimes these big numbers that we see all the time just kind of blur from month to month. And so I broke some of them down into a little finer detail. We saw this month, when you figure that out per day, that's 3,068 patients per day. The two highest diagnoses are still hypertension and diabetes related conditions. Our clinics are last year, and those are year to date we did. I looked at our team do this down by outpatient versus divided by 7 days a week. The hospital $8, and don't realize we're working on trying to get at a point that we're not happy with it, but we're looking at it every day. This providers are seeing through there. One program we don't often mention in this report, patients over 100 miles, at just transporting our patients to and from. Take a look at our, saw 300 patients, take a look at the number of examinations a day. We saw 49.4 or almost 50 a day for emergency exams. Our behavioral health services. You know that we've been working very hard on trying to improve the access to care in behavioral health. And you can see the number of unduplicated and returned patients that we're seeing, but that breaks down to 95 patients a day that we're getting into our behavioral health program. Jack Brown, you know, we opened a new health center not too long ago. Beautiful, beautiful location. And in our old location, we were maxed out at about 20 patients a cycle, and we didn't always have that much, sometimes because of issues with some of the rooms. This particular month, we're up to 27 clients in service, so we're above and beyond where we've ever been, and we're continuing to add some additional staff so that we'll be able to get soon the maximum number of patients that we can into our new Jack Brown Center. Our cancer registry. There have been a number of questions about cancer, and I don't know if you all noticed in our report this month, but we've now started reporting the stage of diagnosis, and we have that in there this month for breast cancer, cervical cancer, and colorectal cancer. And staff is working on that now for lung cancer and a few others. And so as we start getting that data, you'll be able to see how we compare to the diagnosis against all races. And our EMS program this month had 515 calls. That's 17 a day. So in sort of normal working hours from 6 a.m. to midnight, they're hosting about 1 call an hour trying to take care of emergencies. Our recreation center, we show you these numbers all the time, but when you take a look at their total visits, 326 patients per day, that averages out to that total number of 9,788. And one of the services that we offer is child care services to patients, or excuse me, to clients that are there to work out. That number of child care services totals out to about 31 and a half kids a day that our staff are helping watch so that their parents or grandparents are able to work out there. One of the things we also don't mention too often in the oral part of our report are our public health educators and the things they do. And we've talked about our public health program getting ready for public health accreditation. We're still doing that, still waiting on some data back from that national board. But our public health educators are out there every day in the communities. And I would just encourage you to sort of look at that report anew. One of the things you're going to start seeing in there that has not been in a lot of the past reports is something called a Partners in Community Health Grant that we're offering to a number of the communities. And it's to increase fruit and vegetable access, consumption through local farmers markets, farm-to-school programs, tobacco-free schools, and tobacco-free work sites. And when you scan the reports of what our public health educators are out there doing, working on smoking cessation, community gardens, surveying youth for behavioral risk factors, and our youth for body mass index to keep an eye on the obesity in our populations, working in wellness partnerships for their communities, as well as coordinating things with other departments within the tribe. It's really amazing what's going on out there, and those things sometimes occur within the 4 walls of our hospitals or clinics, but most often those are held out in the communities or out in the schools or out in local locations. So I just want to highlight what they do every day. Our public health nurses too, just a quick statistic on them: between their home visits, which they make to provide dressing changes, monitor vital signs, provide education, management of medication, blood draws, assessments of home safety and environment, postpartum follow-up visits, as well as transportation of clients. They had a total number of encounters this last month of 663 with 30.1 per day where they touch our patients out there in the communities. Last but not least on the numbers of the day, contract health services. This month with 9,249 referrals, that comes out to 298 referrals a day, almost 300 a day, for a total spend per day that month of $147,000, 484 per day that month. That's pretty amazing, and that is a 97.9 approval rating, so almost 98%. Just a couple of quick updates on facilities, and then I'll stop and see if you all have any questions. We are now open at Cooey-Scallisaw. We have both of those facilities. We've had their openings, and we've also got staff in them working now. And the 2 remaining ones, Stillwell and Jay, both are still operating in their existing facilities. We're still getting reports from our construction management firm, Cherokee Nation Construction Resources, that we think Wilma Mankiller will be available in May for us to start moving things into, although we don't have a set date yet, and I know they are out. We have a couple of people out, both from CNCR and from Health Services, taking a look at Stillwell today to see how things are going, and reports. I'll tell you a little bit about where we are in the joint venture process. 3 large planning documents completion, and as you near completion, you have to validate all of the things in the Indian Health Service in Oklahoma City. We've had our first meeting with them to start validation of those documents. We have our second meeting with them validating the things that we've put in them. Same thing with Indian Health Service headquarters in Rockville, Maryland, and it will end on that particular project. And I'll close my report with that and see if you have any questions.
Counselor Watts?
Thank you, Madam Chair. Dr. Grimm, so a hospital the size of Hastings, what's the typical rate for ER? You said 221 on average per day?
210, I think it was.
210.
Yeah.
So what does it typically range for a hospital that size?
No, I would have to look up. I don't have any averages.
And what's our occupancy rate in in terms of overnight stay in the hospital beds? What's our average hospital?
Average daily patient load for May was 27.
27 per day or stay in the night? And we're a 55-bed hospital, or?
Well, it's actually a little lower than that because we have several beds dedicated to sleep study.
Okay, that's helpful. And then, are we in negotiations to take over Claremore Indian Hospital? Okay, that's a no. I just need a confirmation on that because there's people saying it is, and I was like, well. So, in terms of the Oshaleta Clinic, how many additional staff providers, either physicians or physician assistants, will we be providing from the old facility? What's the differential? And then what additional services are we providing?
Okay. We, and I sent Counselor Lay a report of the people that we had hired and the actual status of them after the last council meeting. I don't have that on me right now, but we have, I believe it was 27 additional staff that are hired. And that is dental new service that was not provided at Bartlesville. We are adding one more provider. We're going to have a more extensive lab than we had at Bartlesville. We're going to have a full pharmacy. Before we were currying, medications, or else they were going to know audit to get them. Somebody help me. That's off the top of my head. We don't have an optometrist yet, but we have built an optometry clinic there, and Dr. Montgomery has been trying to get a meeting set up with Dr. Lighthizer, who is the director on getting our pharmacy staff in the clinics. We'll be talking with. So that is a new service that we were not providing before. There are, just off the top of my head, a large number of new additional services.
Okay, and one last question. I was glad to see the reports on the stages of cancer being diagnosed so we could better understand what was really happening. But unless I'm missing something, there's not a key, which maybe I am missing it, right?
Well, I don't know. It
So
depends.
there's, the bars show subpopulations of localized versus regional versus distance versus unknown. And we have Cherokee Nation versus all races, but it doesn't say what stage that is. I thought we were breaking it down in stages. Maybe I'm not reading it correctly, right?
You know what, Dr. Montgomery?
That was the way it's provided to me rather than a specific 1, 2, 3, 4 stage. This is the way I think that it's reported for the cancer registry.
Okay, so I guess I assumed when you say by stage, and this was the question I think I had several months ago, was I want to know, are we doing a great job at catching it early in stage 1, or are we catching it at stage 4 when it's advanced diagnosed? And I know that's not all our job. It's also part of the patient's job to come in, which is then part of the public health and the advocacy. I was wanting that kind of look.
I think that's what you get. You get a comparison using the three different classifications.
I'm sorry,
comparing two
walk me
different
through
populations.
this then. Which part of this is stage 1 versus stage 2 versus stage 3, stage 4 in breast
I'm
cancer,
not
for
going to be able
example?
to make a direct comparison by number with each of those stages, but again, you can see sort of the beginning stage, intermediate stage, late stage diagnosis.
Okay.
Which again
The
is
graphs
localized
that I
regional
have
distance.
do not show that.
They-
Maybe I don't have any.
Basically, the localized means that it's right on site, so that would be like a stage 1. I'm gonna.
Early stage.
Early stage. So you can't call it exactly
Okay,
stage 1.
so-
Regionalized means it's spread
Okay,
further
so-
but not distant from the site. So the further you go down this
That's
chart,
helpful.
the
I
worse
thought
it
those were their
gets.
address.
No.
I was like,
That's-
what is this?
So it's localized
So
site,
let's
regionalized, or distant to the primary site. So,
So distant meaning it's metastasized.
Correct.
Okay, could we get like a key for non-medical doctors on this?
Okay.
and so the higher numbers on localized mean caught early. The lower numbers on distant mean we don't catch. I mean, it's lower than that's good. The high numbers in this first part.
No, this is really good.
The lower numbers toward the end means that we're catching a lot of them in the early stages.
He does a good job.
We'd like to see our graphs closer to the pink or whatever color yours, we'd like to be closer to the all races, in all these.
Well, it seems like we have a lot of opportunity though on all three later on because we're significantly higher than the mainstream population.
We're starting to gather this and report it, and it, like I said, hopefully we'll have lung cancer by next time too to put in the report.
Okay, very good, thank you. Now that I know what I was looking at, thank you.
Counselor Buzzard?
And that just answered some of my questions. I was reading the charts and I could not understand it, so. And I was like the counselor over there, that I thought we were gonna break it down by stages, but now that you've explained it, I can understand the chart a little better. I think I want to say, I'm happy that, you're starting to make a report on public health educator. That's been on my mind, but every time I come here, I seem to forget because I've never seen a report until this reporting period. So that's good. And I'm glad, that they're in our community doing the work they're doing. I think they're doing a good job out there. So I like the report and I'd like to continue seeing those reports. The other thing that I wanted just to get a quick overview is the wait times at emergency rooms and stuff. You broke them down by minutes, and then when I broke them down by hours, I don't know if that's a long wait or not. I've never experienced emergency room waits, but is this pretty normal? I think in Tulsa it probably is, at St. Francis or Hillcrest. But like, there's a 170-minute wait on discharge time. That figures out to 2.8 hours. 315-minute wait on ICU to transfer, that's 5.25 hours. Is that pretty normal for our side of the hospital, or close, or?
Brian, you wanna?
We're not happy with it.
Okay, all right, that's,
We're continuing to do things and trying to improve the processes, but by the time, especially someone who's complicated enough to require admission to an ICU, they've
Okay.
gone through typically quite a bit of diagnosis
okay.
and diagnostic imaging, lab results, and things like that, waiting for a hospitalist to come in and see the patient. So if you compare us, nationally, it's pretty close. But we think we have some areas we can work on. That's why we think the lift without being seen is a good metric to look at, because that typically is kind of your best gauge of how well your emergency departments operate.
Well, I wondered, because I've never experienced emergency, and I hope I don't, but I know some people have taken to Hillcrest, there's a long wait up there, so I don't know how we compare them both at the same time. Okay, I think that's good for me. Thank you, Madam Chair. Thank you, Dr. Brown.
Anyone else have any questions? Okay, Victoria.
I just have a comment. Thank you. Dr. Graham, thank you for your additional explanation of the amounts and the number of patients per day. That breakdown was very helpful for me because I kind of tend to get lost when I look at graphs and numbers, and I appreciate it. And also thank you for that phone call, responding to me last week. Thank you.
One of the things, Chuck, I wish you all could look into when you're planning out our expansion. as we continue with the expansion there at Hastings, is the possibility of increasing the room or area for the food, the little restaurant that we operate there. It's come to my attention that we only allow 30 minutes for our employees for lunch. And I'm wondering if we could think about a second line where just the employees could get in there quick, get their lunch, and be able to eat and get it all in within that 30 minutes that we allow them. I think I sent an email to some of you. I'll have to go back now and see who all I sent that to, but that's of grave concern to a lot of our employees that want to eat on site and get back to work, but they're not able to do it even in that 30 minutes because our eating area is very popular.
Okay.
And when we first opened it, it was home cooking, and now it's kind of got away from that. Maybe we could go back to some healthy areas in the home cooking.
Okay.
Maybe
We will
you
look
need
into
one
that.
of our chefs from over at C&B. Or maybe we just, I know we have good chefs there, maybe we
They
just
do
haven't
pretty
turned
good.
them loose with the menu.
And we're also trying to make it healthy too. We have some, and I don't know all the days, but they're doing some special days too, like I think it's Meatless Monday.
Yeah, well,
They're
some of them
trying to
wants
do
the
some-
meat too. And it-
We also got rid of the deep fryers at one point, you
Yes.
know, and that was and people didn't notice, well, they maybe noticed a little, but they didn't complain. I mean, they still do a really good job of cooking there.
They have
so
a really good following.
They do, and
Yeah.
we'll, I mean, if you don't have time to look for that email, enough people that can look into that heard you just now, so we'll look into it.
But I think if we let our chefs go on plans, they can incorporate the home cooking and still get it into the very healthy areas. It's just a different way of fixing it. And I think I'm gonna come have lunch with all y'all so that we can emphasize that
Okay.
point a little bit.
That
So
would
all
be fun.
you folks on that row right there and right here, we might wanna come have lunch with you.
Their breakfast is good too.
Their breakfast is good. It's just so popular now that we're almost gonna start having to
is.
have two lines
It is
and
really
a little bigger space because, you know, the employees wanted that originally.
Yes.
And then the public wanted it, and now it's so popular that we didn't allow enough space for the area.
It really is, and for those of you that might not remember when the tribe decided to take over Hastings and started doing the gap analysis and interviewing employees, that was a huge thing that they all said they wanted back. And so the day the tribe worked on that, the day that they took over, it was able to open. So,
Well, if you only think about them having 30 minutes, they really do want to eat on site. It makes perfect sense to keep them on site too in case of an emergency that you might have to call them out for. So we need to make that as easy as possible, and dare I even throw in here, maybe give them a little discount because they are our employees. I mean, it's not that end of the hospital was not to try to make a profit, it was to provide a service.
that's
So
correct.
just something for us to think about.
Okay.
I appreciate it.
Look forward to a lunch day with you soon.
That's what we're gonna do. Thank you all.
Yeah, good point.
Councilor Hyde?
Thank you, ma'am. I'd like to thank the health department and the expansion of the clinics especially and to come to the hospital. Here's something I can tell you. I have never been able, in 12 or 14 years Bartlesville has been open, to get an appointment at Bartlesville. And of course, we had to drive somewhere else, maybe Mount Bonita, to get dental. I now have a medical and a dental appointment at Oshaleta. And so if you give people a place to work, then they can work you in. This has been our problem, at least where I come from. And thank you.
Well, beautiful, beautiful place, and it's going to be exciting to see it full of people.
That's good.
Any other comments or questions?
No.
Okay, Frankie?
I seen on the recruitment page that Dr. E has left Stillwell, is transferring to urgent care. Has he already done that? Do we have a doctor in place at Mankiller? to take his patients?
I believe he has transferred, didn't he? Yes, and you know, we have Dr. X. We, Dr. Montgomery said we have a nurse practitioner in his place right now. And you can see that we are still trying to do some recruitment there.
I also have another question. I had a lady that was in the dental office last week, and I don't know what the treatment was, but they told her she needed another appointment. If it wouldn't make her an appointment, told her she'd have to call. Is that our comment, is that our practice? I mean, we know they're already in need of that?
If they come in on emergency care as a emergency walk-in, and we tell them that they need additional care, then they have to go back through the process just like everybody else to get that exam appointment. We'll still treat their emergency needs as needed, but we don't put them in front of people who have already been through the process and got their exam appointment. And that's just the way of, but we offer those appointments every day. So if there's not a waiting list or a line, they have to go through the process just like everybody else. We don't feel like it's fair to have somebody come in as a walk-in and who's gone through and done what they had to do to get into the system to get all their treatment completed.
Well, you really wouldn't be putting them in front of someone if they're all already scheduled, and then you're just adding to the schedule, would you?
Well, if it's usually their emergency care that they're wanting back. You know, we do the emergency care and get them out of pain. And then we encourage everyone to do a complete exam so we can look at the whole mouth, not just their emergency needs. So we're not going back and backtracking. We try to fix everything in an area at a time. So you're not backtracking, doing this tooth and come back and you have to do another one in that same area. So, because those walk-in appointments are worked in, so the time frame that we spend with those people who have appointments have priority because they've taken off their work or whatever their schedule is and made an appointment, and we work those in and get them out of pain, but we don't have the time to spend a full 45 minutes or an hour with that person to do all their treatment. And it's not really fair to those people who have made arrangements to come in.
Well, no, I understand that. What I'm saying is they wouldn't make her an appointment to come back.
If it's something that has to do with that acute situation, they will do that. But if it's something in a total different area, then they have to come back in as a walk-in again, or come back in and get an exam.
I do have an added question, Steve. So we're not, let's say we fix their bad tooth. Now we're suggesting to them that they have an overall exam.
Right.
Are we saying that we would not make them an appointment then to come out however far we need for them to come out for that annual exam? We're telling them they have to come.
Yes, they have to call in the morning at 8. Required to do 4 new exams every day. So we have a certain amount of appointments to give away every day. Before when I first came in, they were doing it one day a month, a little bit of their time in getting that appointment. If we were to just give those appointments out to every walk-in that came in, then our no-show rate goes way up because they're not invested. So we have a huge broken appointment rate. This way, they've made an effort to make that appointment. They are invested in that appointment. Our no-show and our cancellation rate has gone way down.
Okay, are you also utilizing before their
Yes.
appointment?
3 days with them.
Did that not improve your drop
It does.
missed rate?
It does, and it keeps and once you've had that exam and you had your treatment completed with our hygienist and have your cleaned, then you have the option of making your appointment in 6 months. So once you're into the system, it will continue to revolve, and you don't have to go through the call-in process again. You have the option of making that at chairside for your 6-month recall.
So each dentist, each day, is taking in 4 new appointments for sometime in the future,
For a month away.
month
Yes.
away.
So every day, they open up 4 appointments, and 4 time slots are open for new patient exam for each doc that's scheduled on that day.
And how many dentists do we have now? Throughout the system?
Just figure that up. 20, I think we have 21, I think.
Okay. So we're taking basically 84 new clients in daily.
Yes, if they show up for their appointments, and that's where you saw the discrepancy.
Well, we're making appointments
Yeah,
for
we're making
them.
appointments for them, and you saw the discrepancy in the report, we had an average of 66, so we still have that
We have about
percentage of
25%
people who
gap.
don't show up for their appointments, and.
But at
so-
this rate of 84 a day, times, I guess it's 5 days,
Mhm,
for a work week,
right.
you're taking in 420 new
Yeah,
patients.
But our docs are flex time, so some days you may have, they work 10-hour shifts, so you have.
4
let's say-
days.
Let's say a clinic that in Stillwell, you have 3 docs, so you're gonna have one doc work Monday through Thursday, one doc works Tuesday through Friday, and one doc works Monday, Tuesday, Thursday, Friday. So some days you're gonna have 3 docs, some days you're gonna have 2, so that
But
number
even-
fluctuates.
Even at that rate, we could be taking in the system, anywhere from 350 to 400 new patients a week.
Probably around, yeah, closer to the 350.
Okay. So over a period of time, everyone that wants to use dental services are going to get into the rotation.
Right, and that's where we've increased access by doing it that way. We've actually increased the amount of appointments that are available to new patients. Now, if we have a patient that comes in and walk in and they have a situation where it takes multiple appointments to take care of that acute need. So let's say it's a tooth that's abscessed, they need to be on medication for a few days before they can actually extract it or do a root canal on it, then they're gonna be reappointed back for that appointment with that same doctor. They're not gonna be just a good luck call again.
But that, on the average, then, if you move that out, is 1,400 new patients a month, and over a year, that's
A lot,
16,000 new patients a year.
right?
So eventually, everyone that's within our program area will be in our system, if they want to be.
If they want to be.
Okay.
And the caveat to this is, if someone is a new patient and then they don't reschedule for that 6-month recall, say they go 14 months, well, they're a new patient again,
Mhm.
okay? They didn't stay within the recall system, so we have to do a complete new examination, because a lot of things can happen in 12 to 14 months.
And the way that the patient can help the system, is don't miss your appointments if at all possible.
Right.
Because that drop down rate is 25, basically it's 25%.
Right.
Okay.
And
And we weren't doing that a couple of years ago.
no, it was we called in one day for, they
One,
gave out
once a month.
once a month, yeah,
And now you can call in every day.
every day.
Okay.
And actually, we don't fill those every day. So some days, say today, they didn't fill those appointments. Tomorrow at 8 o'clock, any appointment that didn't get filled yesterday gets filled first. And they don't just block it off a book. Those appointments still get filled in.
And that one day a month before, I think, was only for 30-some appointments, I believe.
Right. That's
Where-
approximately 1 patient per doc per day.
Okay. So now we're doing 75% more of the work.
Right. We've increased
work.
access about 38%.
Okay. Thank you very much.
Yeah, I have, further on in the reports, I did see where there was some radon problems up in the physical therapy room. Do we know what's causing that? It's not in your report.
I was gonna say.
It's in the environmental.
Yeah.
Mr. Jones may know about it.
I mean, we've been, if it's the one I'm thinking about out at Hastings, we've tried, we have worked on it. I think we have remediated that. Now, is that correct, Ryan?
Yes, it's been successfully remediated.
Okay, well, I was wondering about it, because I did see the report. And I just thought it was strange that you only have it in that one particular building there.
It is.
The hospital has a French drain system already underneath it. It was constructed that way.
Yeah.
This new annex building did not.
Oh, I see.
So when
And
they
that,
tested it, they found higher level of radon, so they installed a drain system that pumps it out. So they cleared it now.
okay. Well, I saw it in Tom Elkin's report, and I don't know if you probably knew about it. Okay, so, thank you.
Anyone else? Counselor Watts?
Thank you, Madam Chair. I was confused, I guess, so I was trying to figure out how, like, normal Jane or Joe Cherokee would understand the process. So you do have to call every morning, and there's 4 or 5 slots that each dentist has. So you call whatever respective clinic it is, and you hope you can get to that. It's like, I guess, a radio, like, contest, right? You have to beat them in. So do we know how long it typically takes somebody to make an appointment using that process?
When I first came on, there were my desk was constantly filled with complaints about access. I rarely get an access issue now. So evidently, it's working. And
We've
patients
received
that-
different feedback, so you'll be getting those now. Okay,
well,
very good.
The patients that are encouraged to call, and if they have 2 or 3 times and they don't get in, and I do get that message, then we facilitate helping them.
Okay,
But typically, we don't, not all clinics fill their quota every day, so, so we do have some time prior to, so, from the day before or 2 days prior to, so that there's not a waiting list. We haven't had a barrage of calls like we were when we first opened this up.
okay, and so if are we gonna grow our dental staff that we're growing this patient load? I know that you
Grow our
had some
space.
efficiency
There's only, if you
gain.
get too many dentists in a clinic, then you lose efficiency because they don't have the chairs to work out of. So we're limited to our space and how many chairs we
Which
have
is
to work
why
out of.
I'm trying to understand the impact of your decision that they all have to see 4 new patients a day.
Mhm.
That means there's a huge amount of growth. I'm trying to reconcile those numbers. We're
So-
increasing the patient load, we've had some increase
So
because
we've
of
also-
efficiencies.
Okay, so I'll answer that, but we've also increased we've changed the philosophy of doing quadrant dentistry, which means you do everything in the area at the time you have that area anesthetized, rather than picking and choosing a couple little things to do each time. So each dentist is more efficient with their time, with their appointments, with their patients. And you can see that in the production numbers that we've shown over the last 2 years in our increase in production.
I guess I was trying to project out the numbers in my mind because that's a lot of patient load. I guess they'll either work out or it won't, so.
And some patients have a lot to do, and some patients have very little. If they're in a recall system and they're doing what we're asking, their recall appointment may be the only appointment they have that week.
Okay.
They may not have any recurrent decay where they have any other dental needs that need to be addressed.
Okay, thank you, Dr. Jones. Thank you, Madam Chair.
Yes. Counselor Fishenhock.
So, Dr. Jones, what it amounts to is y'all's increase in efficiency in several different areas
Right.
that combines to the growth, whether it be having the doctor work in just, I went through that with my son with another dentist. He worked here, and I thought, why didn't you just get them all on this one side? Why, it was not.
Yeah.
So you're looking at it different. You're telling them to get that side or to get that area and then go on to the next one later.
Right. Times.
That's right.
So we try to make the time efficient for the provider as well as the patient.
Okay, I'm glad to hear that because a lot of my patients, hate to miss work because, not only because of the boss and points, just, I relate it to like Bobby when she's in an operating room. She wants to run from one to the next, back and forth. And that's what you're doing with dental chairs and dentists now. Number where it's the most efficient
We're working, not we're sitting in our office. So.
or waiting. So a hygienist can be working on this one, getting it ready while the doctor's over here before they.
Absolutely.
Okay, well, I understand the growth in your numbers then and how much better it is now.
And that's part of the flex time, but the flex time allows more chairs available for working the 10-hour shifts. You have a few less, if you have a 2-doctor day, there's more chairs available for more to be seen.
I feel bad that
Thank you.
Then I have comments.
Dr. Jones, 2 years ago, I've had a long discussion with you in your office, and we had many complaints then, before you implemented this process. I haven't received hardly any complaints with this new process that you implemented. During I want to commend you on this process here, your efficiency and.
Can you share with me Because this is, I've got a specific example of a family member who had a dental appointment, and the clinic called him and it was canceled on voicemail. There was no, can you enlighten me a little bit as to what the process
Or
is?
it's not typically the way it's supposed to be. Typically, what's going to happen from this point forward is if a provider has to cancel a patient that has a scheduled appointment, then they're going to be responsible for trying to work that patient in at an earlier time or at that patient's convenience, because that patient has made the situation you're talking about, I think that you're talking about, that I was made aware of, happened 24 hours prior to the off work or scheduled off work. So we can be more customer service and more cognitive of our patient's time. And I've addressed that with the provider, and we'll be doing that a little differently from this point on, because that's not being customer service oriented to our patients.
Okay.
So
Now, if someone is calling in, we don't have a cancellation situation or anything like that, but if someone is just calling in for an appointment, what is the amount of 3 months typically?
30 days is we schedule our exams.
So everybody who tried to schedule
If they
within
have
the
an
30
acute
days.
need, then we encourage them to come in and let us go ahead and take care of the acute need now.
Right.
And that's as a walk-in basis.
Right.
But our 30 days out is what we're scheduling our exam appointments.
Okay, good. Thank you.
Councilor Fisher?
I got a question. Are they gonna let you keep in dental the profits that you earned this year?
That's not my decision.
Okay, thank you. We'll consider that during budget hearings.
Well, I want to thank you for a job well done, and I can remember the way it used to be down at Redbird and that one day a month thing. They almost had a riot down there one day. The line wound all the way outside. It was raining and people were cussing and calling me and calling everybody. And when they got up there and they'd driven a long ways to get there, they had a little sign on the door, and it was like before Thanksgiving, and they decided they weren't going to take the appointments that day. I mean, it was mass chaos. People were mad. Well, they did write a letter and apologize a week or two later, but it didn't help the situation. And I just think you've improved things so much, and all that back money that was invoiced for things that hadn't been done on, Sooner Care and things like that, and the big chunk of money you made us when you took over. I just think it's improved 100%. I know it has at Redbird because we've got 3 dentists down there and the Taj Mahal Dental Clinic, and we didn't have that before. So I really appreciate the improvements that have been made in dental.
Thank you.
We all want to keep our pearly whites and keep them pretty.
Yes.
Any other things? If not, thank you, Dr. Grimm.
Thank
We
you
loved your
all.
report.
Appreciate all that you do for us every day, all of you.
Good job. Okay, we have no old business and no new business. Announcements? Okay, our next scheduled meeting is Wednesday, July the 29th at 1 p.m. I entertain a motion to adjourn. All right, everybody in favor of adjournment, let me know by saying aye. Aye. We are adjourned.
They come at time you need.